Hello everyone. Today we will be discussing dysmenorrhea. Dysmenorrhea as a clinical topic also if you get a case in your exam, and a theory topic for MCQs as well as for your theory papers. Dysmenorrhea, as the name suggests, dysmenorrhea. Dys means painful and menorrhea means menses. In medical sciences, most of the time you understand what the term means by the meaning of the words, by breaking it into pieces. So, dysmenorrhea means painful menses, literal meaning. But the actual and better definition is painful menstruation of sufficient magnitude so as to incapacitate day-to-day activities. That is very important. If somebody asks you what is dysmenorrhea, little bit discomfort is not termed as dysmenorrhea. Dysmenorrhea to that extent that the woman is not able to perform her routine activities is mainly problematic, and we need to diagnose it and treat it. There are two types, primary and secondary. We will be talking about each. Primary dysmenorrhea or spasmodic dysmenorrhea. Please remember the other name also because it is more commonly used. As the name suggests, spasmodic. Primary dysmenorrhea is one where there is no identifiable pelvic pathology. This is very important. No identifiable pelvic pathology. That means if you will go for investigations, the investigations will turn out to be normal, but still the patient is having extreme pain that she is not able to perform her activities. The incidence is around 15 to 20%. It is a high incidence. So, in normal population, especially unmarried young girls, you will find primary dysmenorrhea or spasmodic dysmenorrhea. What are the causes of pain? See, if there is no pathology, why should it be a pain? Because menses is a physiological thing, but still it is painful. Why? So, the mechanism of initiation of uterine pain is difficult to establish. No one knows what is the exact reason, but yes, there are some associations and theories where you can predict that yes, it is a high risk thing and this patient may have primary dysmenorrhea. So, mostly confined to adolescents, definitely. Once menarche is there, the patient or the girl starts bleeding, starts having menses. Initial couple of years are generally anovulatory bleeding, that is irregular bleeding, and mostly the woman, the girl is not having any pain. But as the regular ovulation gets established, pain also surfaces. So, it is generally found in adults, almost always confined to ovulatory cycles. We should know this because in evaluation of a case of infertility or talking to a girl while doing a counseling, this is very important. We can tell her that you should be happy that you are having ovulation regularly, so you are a normal woman who is ovulating regularly. So, if the pain is bearable, be happy with that. The pain is usually cured following pregnancy and vaginal delivery. This is a common association. Vaginal delivery is necessary because in the theories we will study that cervical stenosis or the tightness of the muscles of the cervix, it leads to dysmenorrhea. But once there is vaginal delivery, the cervix becomes lax and petulous. The pain is related to dysrhythmic uterine contractions and uterine hypoxia. Dysrhythmic uterine contractions, that means it is not a normal propulsive action. Dysrhythmic, there is no rhythmia. Now, uterine myometrial hyperactivity can be a cause. What I was talking about, what we studied in the lecture of endometriosis, that there is this uterus and the endometrium, and the myometrium is divided into two zones. This is the JZ or junctional zone, which is the subendometrial layer of the myometrium, and this is very important. In cases of endometriosis also we find the implants over there, here, and extreme dysrhythmic activity over here. So, any dysrhythmia of junctional zone will leads to dysperistalsis and myometrial hyperactivity, which will lead to pain. So, pain is mainly because of dysrhythmia of the junctional zone. Imbalance in the autonomic nervous control of uterine muscles. It is important to remember that the primary dysmenorrhea is the one dysmenorrhea which is associated with autonomic symptoms also. So, the autonomic nervous control is a bit imbalanced during the menses and it leads to multiple plethora of symptoms. Role of prostaglandins is very, very important. We know that PGF2 alpha and PGE2 have different actions on the musculature as well as on the uterine vessels. It can cause ischemia, it can cause vasoconstriction of the vessels and uterine angina. There is pain like that of angina, and yes, it may cause more tightness of the cervical isthmus region, so more and more dysmenorrhea is there. So prostaglandin is always produced in the presence of progesterone. That's why we are saying that if there is action of prostaglandins in the body, that means progesterone was there and that means ovulation was there. Kindly correlated with the menstrual cycle also. Role of vasopressin. Nobody knows whether there is role or not, but yes, the increased vasopressin released during menstruation is noted, and these women who have increased vasopressin have dysmenorrhea. So there is some association, but exact association is not known. Endothelins. Local myometrial ischemia is caused by endothelins and PGF2 alpha, and it increases the pain. Platelet activating factor is also associated. So we should remember these names and the associations. Uterine myometrial hyperactivity, imbalance of autonomic nervous control, prostaglandin, especially PGF2 alpha, PGE2, vasopressin, endothelins and PAF. This is a small flow chart which tells us that the progesterone, in the presence of progesterone, there is excessive release of PGF2 alpha, and endothelins, leukotrienes and PAFs are released. There is reduced blood to the myometrium, which I talked about vasoconstriction. So it is myometrial angina. It causes pain. There is increased myometrial contractions in the junctional zone and dysrhythmia. All of these leads to pain. 1, 2, 3, 4, 5 factors are very, very important. Now clinical features. Whenever someone asks you about the history taking, clinical features, management, you should always start from a good history taking. Half of the job is done by good history taking of the patient. So it is predominantly confined to the adolescent girls. So first of all, in the personal history you will find the age, whether she is from affluent society or not, what is her job profile, etc, etc. So adolescent girls, it usually appears within 2 years of menarche. It appears once menarche is there after 2 years, because after 2 years we find that the ovulation is nicely established. And the mother or sister may be dysmenoric. It runs in family. And it is in the affluent society. Generally you will find that the girls from affluent society are complaining of primary dysmenorrhea in a more proportion. Now classical symptom of pain, if you can ask, you can take out from the patient how the pain starts, how it increases and how it decreases, your diagnosis is absolutely clear. So the pain begins a few hours before or just with the menses. It is not like that I had pain from 1 week and then I started bleeding. No, either few hours or just with the onset of the menses the pain starts. The severity of pain usually lasts only for few hours, initial 12 hours probably, but may extend up to 24 hours, but not more than 48 hours. So the pain will last only for a few hours. 24 hours is okay, it may last up to 24 hours, but not more than 48 hours. This is very, very important. It differentiates between primary dysmenorrhea and secondary dysmenorrhea. The pain is classically spasmodic and confined to the lower abdomen and may radiate to back and medial aspects of thighs. Systemic discomforts like nausea, vomiting, fatigue, diarrhea, headache, tachycardia, it may be associated, because we studied it is because of the autonomic nervous control, the imbalance between the autonomous system also. And it may be accompanied by vasomotor changes, so pallor, cold sweats and occasional fainting. So if you find these systemic discomforts and vasomotor symptoms, then it is primary dysmenorrhea. In secondary dysmenorrhea you don't find any accompanying system. Now diagnosis. We are trying to stamp our diagnosis, which is very, very difficult. So history taking is the only way in which you can find out the diagnosis. The abdominal examination or rectal examination. Why it is mentioned rectal and not vaginal examination? Because these are generally young unmarried girls and we do not perform a per vaginum examination until and unless it is extremely, extremely important. So a per rectal examination and abdominal examination is always normal. You will not find any pathology. And if you go for ultrasound to rule out anything, but you will not find any pathology in the ultrasound also. How will you manage such a case? Now these girls are extremely annoyed and they are like we just want to get rid of this pain. First of all, a good history taking, and you should know that yes, whether we should treat it or only assurance or counseling is okay. So assurance or counseling is the first, foremost and the most important step. So elicit a good history and try to stamp it as primary dysmenorrhea, try to counsel that this is ovulatory thing. Most of the primary dysmenorrheas, the girls respond to assurance. But if she is not responding, we can start off with simple analgesic medicine, non-steroidal anti-inflammatory drugs, anti-spasmodic drugs like dicyclomine. We should ask her to keep the bowel empty so there is no more constipation and problems, and encourage the normal activities. Ask her to continue her normal activities so that things become normal. But if the basic things fail, then what to do? There are two categories of such patient. One is an unmarried adolescent girl who wants to study, who wants to play. So your primary thing will be prostaglandin synthetase inhibitors. These girls, we generally don't put them on hormones of any kind, and we start with prostaglandin synthetase inhibitors. And there are girls who want pregnancy, so we are also not giving any oral contraceptive pills in those cases. So those who want pregnancy, there are contraindication of pills. That means she is intolerant to the hormones. So we go for PSIs, prostaglandin synthetase inhibitors, for 3 to 6 cycles, and the patient generally responds for that. But if the patient is a woman who wants contraception also, there are some contraindications, some allergy for the PSIs, and she is ready to take pills, then we will go for oral contraceptive pills on a regular basis. And the funda behind this is that the oral contraceptive pills, the mechanism of action is it inhibits ovulation. So once ovulation is inhibited, the whole cycle stops and there is complete relief from dysmenorrhea. So it is always a patient tailored management, that what your patient wants. If she wants contraception, she is ready to take OC pills, go for OC pills. If she does not want contraception, she is ready to take prostaglandin synthetase inhibitors, go for that. These are both the primary medications for primary dysmenorrhea. Oral contraceptive pills for 3 to 6 cycles generally are sufficient, or there are women who are a bit elderly in age or they don't want to take pills. You can go for levonorgestrel intrauterine releasing device or Mirena. Mirena is a magic thing. We are using it in almost every condition and it is giving very, very good results. So if there is no contraindication of either, you decide that the patient what does the patient want? She wants pregnancy, go for PSI. She does not want pregnancy, go for OC pills. But if both of the management fails, you have given all the medical treatment, you have tried LNG, IUD, it is failing. So you are wrong in your diagnosis. There is something else that we are missing out. What is that? Go for ultrasound again, go for laparoscopy to rule out endometriosis. We have taken this in the class of endometriosis, that endometriosis generally is such a silent disease that it would not show even on USG or MRI. So go for a laparoscopy, which is gold standard, and rule out endometriosis, because endometriosis is the most common cause of dysmenorrheas. Laparoscopy, we find that yes, there is endometriosis, then treat it, do the excisions. If not, and the patient is still not responding, and on laparoscopy also you are not finding any endometriosis or any positive finding, then these three things can be done, but these are very, very rare and generally not required. You can go for uterine nerve ablation, You can go for pre-sacral neurectomy just to relieve the patient from the pain, and dilatation of the cervix just to think that the cervix is too tight for the blood to pass through it, and dilatation of the cervix is very rarely done. In fact, all these procedures are very rarely done. They are only for theoretical purposes. Now, what are the drugs of choice? Amongst all the drugs which are best to be used in primary dysmenorrhea, mefenamic acid is the drug of choice. 250 to 500 milligram 8 hourly you should give to the patient. It will alleviate the symptoms like anything. If it is not working, we can go for ibuprofen 400 milligram 8 hourly, naproxen 250 milligram 6 hourly, or COX-2 inhibitors. This is important. See, we don't want more side effects to occur because she is already suffering from autonomic problems like nausea, vomiting, headache, diarrhea, etc. etc. And if we are giving any strong NSAIDs, then there may be gastritis, which is the most common side effect of NSAIDs. So better to go for cyclooxygenase 2 inhibitors. As we know that prostaglandin synthetase inhibitors or NSAIDs, they are inhibiting cyclooxygenase enzymes which are COX-1 and COX-2. So any drug like celecoxib, which is selective COX-2 inhibitor, will produce less side effects, and then it becomes a drug of choice for those people who are having more side effects like nausea, vomiting and gastritis. Now, combined oral contraceptive pills can be given. Any pill which is suiting your patient. Like if the patient is having acne or the other symptoms, go for anything which is having anti-androgenic things, or you can go with low dose or high dose depending on the BMI of the patient. Oral progestogens like dydrogesterone from day 5 to day 25 of the cycle can also work, or LNG, IUS or Mirena. These are all the cafeteria approach basically, that you have to try and see which drug is working for which patient and which patient is more comfortable with which medicine. Now with this I am finishing primary dysmenorrhea, and now I am shifting to secondary dysmenorrhea. Secondary dysmenorrhea or congestive dysmenorrhea, the name is highly suggestive. Primary dysmenorrhea was spasmodic. This is congestive. That means there is some pelvic pathology. So secondary dysmenorrhea is considered to be menstruation associated pain occurring with the presence of pelvic pathology. Presence of pelvic pathology is the catchword over here. So the pain may be related to increasing tension in the pelvic tissues due to premenstrual pelvic congestion. We know that there is a premenstrual pelvic congestion or increased vascularity in the pelvic organs. Always prior to the menses there is high level of like bloating and congestion of the abdomen and pelvic area of the patient because of the interplay of the hormones, which we have already studied in the menstrual cycle. What are the common causes? What I was talking about, that endometriosis is the one which is the king of all the causes because it does not show in any investigation, and secondary dysmenorrhea not responding to any medication. You do a laparoscopy and you find there is endometriosis. Other things what you can find, adenomyosis, any IUCD which was being kept because of the contraceptive usage, and then the uterus is not able to accept that IUCD. Obstruction due to Mullerian anomalies. There are Mullerian anomalies, that means uterine anomalies, congenital anomalies, right? Cervical stenosis. What I was talking about, the cervix is too tight and the blood is also not able to pass. So there the uterus is pushing and there is pain. Pelvic adhesions, uterine fibroids, pelvic congestion, endometrial polyp, chronic pelvic infection. Main topics we have already covered in the separate lectures because each of them is a separate pelvic pathology which we have to deal accordingly. Now clinical features, see the difference. The patient is usually in 30s, not the adolescent one, and more often parous. She is already having kids and unrelated to any social status. It is not about affluent or something. It is more than 30 years, she is already having kids, but now she is developing dysmenorrhea. This is a recently acquired dysmenorrhea. The pain is dull, mind it, not spasmodic, dull, situated in the back and in front without any radiation. Usually appears 3 to 5 days prior to the period. That means when the congestion starts, the pain starts and relieves with the onset of the bleeding. Once the bleeding starts, it stops. But in cases of primary dysmenorrhea, the pain starts with the bleeding and lasts for a few hours and then it is relieved. There is no systemic discomfort. It is not associated with any autonomic symptoms. And in examination, whenever you will do any abdominal examination or vaginal examination, you will find any pelvic pathology, which we have already talked about in the individual lectures. Now investigations. The woman is coming to you and we need to investigate. So in any such cases, Paris woman, we go for a transvaginal sonography, which is the gold standard investigation for any gynecological problem. So in transvaginal sonography, you may find any pathology like leiomyoma, adenomyosis, whatever. Saline infusion sonography can be done to rule out submucous fibroid and polyps. We have done it very nicely in the lectures of the fibroid. Laparoscopy to rule out endometriosis, PID, and definitely during laparoscopy you diagnose as well as you treat. Hysteroscopy is also useful for both diagnostic and therapeutic purposes. Basically, secondary dysmenorrhea is all about pelvic pathologies, and according to the diagnosis you need to treat that specific pelvic pathology. The treatment aims at the cause rather than the symptom. So if you are seeing any fibroid, remove that fibroid. If you are seeing any polyp, remove that polyp. If there are adhesions, go for adhesiolysis. Whatever is the diagnosis, go for the management of the pathology and the pain will be relieved by itself. But in cases of primary dysmenorrhea, we are curing that pain, not the uterus. This is like differentiation between primary and the secondary dysmenorrhea, and if you remember this chart, your whole of the dysmenorrhea topic is already done. So primary dysmenorrhea, definitely no identifiable pelvic pathology, but in secondary there is definitely a pelvic pathology. It occurs in young adolescent girls, it is elderly Paris women. History taking, confined to ovulatory cycles, and it has nothing to do with the ovulation. It is to be done, it has to do something with the congestion. So here the pain starts 7 to 10 days before the onset of the menstruation, and it starts with the onset or just before the menses. No systemic discomfort, and most important, intermenstrual period is not completely pain free, that the patient is having a dull aching pain which is there for whole of the 30 days of the cycle, but it increases during menstruation and it is dull aching at the rest of the time of the cycle. But in cases of primary dysmenorrhea, rest of the month goes absolutely pain free. So this way, by the age, by the occurrence of the pain, by looking at the symptoms and the pain graph, you can actually differentiate between primary dysmenorrhea and secondary dysmenorrhea. With that, I finish off this topic of dysmenorrhea. Thank you so much.